I am Michael Medvecky from the Department of Orthopedics and Rehabilitation, Yale School of Medicine, and Yale Haven Hospital.
And I'm Jory Kahan, an orthopedic surgery resident at Yale School of Medicine. We are appreciative of the opportunity to present our paper titled The Pathoanatomy of Posterolateral Corner Ligamentous Disruption in Multiligament Knee Injuries is Predictive of Peroneal Nerve Injury.
There is little information in the present literature describing the precise location of injury to the structures comprising the posterolateral aspect of the knee. The goal of this study was to characterize the ligamentous and myotendinous injury patterns and zones of injury that occur in acute posterolateral corner injuries in the multiligament injured knee, and to determine associated rates of dislocations, fractures, peroneal nerve palsies, and vascular injuries. Specific zones of injury were defined based upon location of injury, such as proximal avulsion, mid-substance tear, or distal avulsion. All structures of the lateral and posterolateral aspect of the knee were analyzed by MRI and by surgical assessment on operative cases.
We examined all patients who sustained a multiligament knee injury at our institution from 2001 to 2018. We identified 100 patients with multiligament knee injuries, of which 74% were found to have a lateral-sided ligamentous injury. Patients with a posterolateral corner injury had statistically higher rates of peroneal nerve injury compared to acute multiligament knee injuries without a lateral-sided injury.
Of the 74 patients with a posterolateral corner injury, 96% had injury to the lateral collateral ligament. 3 distinct patterns of injury were observed based upon location of injury to the LCL, which was predictive of peroneal nerve injury. Distal LCL fibrillar avulsion was the most common injury, seen in 65% of the LCL injuries. Proximal avulsion was seen in 20% of the LCL injuries, and mid-substance tears were seen in only 15% of the lateral-sided injuries. The distal avulsion injuries were further subclassified based upon the number of posterolateral corner structures avulsed off of the fibular head. This classification system demonstrated that there were statistically significant differences in rates of peroneal nerve injury between injury class, and that injury class is predictive of peroneal nerve injury.
So overall, the big take-home messages to this study are the following. When posterolateral corner injury occurs in the context of a multiligament knee injury, the LCL is nearly always involved. A distal avulsion was the most common form of injury to the LCL that we observed, seen in 65% of patients. Mid-substance tears were seen in only 15% of the lateral-sided injuries. Multiligament knee injuries with involvement of the posterolateral corner are more likely to suffer peroneal nerve injury when compared to those without posterolateral corner involvement. And finally, location of LCL injury is predictive of peroneal nerve injury.
We thank you for taking the time to learn about our study, and we hope this investigation into the pathoanatomy of acute posterolateral corner injuries provokes further research into this uncommon injury. We look forward to see if this posterolateral corner injury classification may help guide more focused outcomes research based upon injury patterns. Thank you.